I would like to thank at the outset Government of Kerala for inviting IDSP and CDC to share our views on this public health emergency of international concern. I would thank Dr. Pragya for that elaborate presentation wherein she covered almost all the aspects of this public health emergency, and therefore makes my job a little bit easier so that I can restrict myself to the surveillance and response aspects of monkeypox virus disease. So I hope my slides are visible and I'm all able to change, and you can see as I change my slides.
Yes, yes.
So the background has already been set. We know that it's a viral zoonotic disease with symptoms like smallpox, but on a much milder scale. The first cases being reported in 1958 in colonies of monkeys kept for research, hence the name monkeypox. But we should also at the same time realize that the name has stuck, but now we are looking at a disease which has a human-to-human transmission, and therefore the initial zoonotic part of it, wherein it had to make the virus had to make that leap probably already has been made a long time ago. And the first cases were identified in 1970s in DRC, the Democratic Republic of Congo, in humans. According to WHO, this is the first time that chains of transmissions without known epidemiological links to West or Central Africa are quite evident. And therefore, taking cognizance of this fact and also gaining from the lessons learned during the COVID pandemic, the WHO took the call early on when we were looking at around 17,000 cases to declare this as a public health emergency of international concern, which in public health terms is the highest magnitude of attention or emergency that could be accorded to any infectious disease. Dr. Pragya has already touched upon this. So just to quickly run over the slide, we know that there are 82 countries which had not historically reported monkeypox virus disease. It was initially limited to the 7 countries, the blue dots that we see in Western and Central Africa. And now it's a public health emergency of international concern. Globally, almost 89 countries today, they are reporting and the number seems to increase day by day. Dr. Pragya had mentioned around 32,000. My data says that, yeah, it's close. Maybe the timelines are slightly different, but 31,425 cases from countries that have not historically reported monkeypox. So it is essentially an epidemic which is outside the traditional endemic zone of that disease, what we are seeing right now. The deaths, although they are low, with so far 11 deaths, which also includes the one death which is still under investigation from India, but it has been notified to WHO. So total 11 deaths. As I said, the number of deaths at the moment is low, and therefore the kind of impact that it makes in the general psyche of people and decision makers at large may slightly be skewed by the fact that this disease isn't a lethal disease. We'll talk about this aspect a little more in the subsequent slides. As we know, in India, we observed our first case diagnosed on 14 July 2022, and a total of 9 cases, including one death. Just in a timeline snapshot, if we look at what are the important events, so May 2022 was when the first case of monkeypox was reported from a non-endemic country. 22nd May, if I recall correctly, was the exact date. Recognizing that, and as it progressed over the next 1 week, more and more cases were reported from different countries, and these were all independent foci which were not epidemiologically linked. So the government of India took a call, and on 1st June 2022, we had released guidelines on management of monkeypox disease, which still continue to serve as the guiding document. This is a comprehensive document capturing almost all aspects of the disease. After a little while, from 1st June, 1.5 around 6 weeks later, we were expecting that at some stage, as the epidemic is progressing globally, we anticipated that at some stage we would be seeing. And on 14 July, our first case of monkeypox was reported. As we know, an international traveler. And as the scene unfolded with the number of cases continuing to grow, WHO also took a call and declared it as a public health emergency of international concern. The NCDC also issued a CD alert, which is our communicable disease alert, which is capturing. So because the guidelines which were released on 1st June and between 25th July, there were some new developments, there was some new data set available, and all this was captured, and this CD alert can be considered as an update on the earlier MOHFW release guidelines. And on 2nd August, when we saw that the country is reporting more cases, although predominantly related to international travel, but when the Delhi cases were also reported, on 2nd August, we took the call and we activated our emergency operations center at level 2, which is again a phenomena that we reserve for the epidemics or conditions of high magnitude. Just to take you quickly through those 9 cases, in addition to what has been already mentioned, we know that predominantly it is males. This is gelling with the data that has come globally from different sources. We have seen 5 cases in Kerala and 4 in Delhi. The median age is 33 years, which is also quite nicely gelling with what the evidence from almost all countries point towards, that mid-30s is the age. 6 Indians and 3 African nationals are the current 9 cases, lab confirmed cases. All the cases of Kerala reported international travel history, but on the other side, in Delhi, we see 4 cases, and none of them have a travel history in the recent 1 year at least. So this is quite an interesting fact, that although we may take refuge, for the lack of a better word, that our cases are related to international travel, at least in the case of Kerala. But in Delhi, what we are seeing is an indicator towards finding which may have public health implications later on. And these cases also had comorbid conditions. One case has diabetes mellitus. Another case, the female case, is also suffering from abdominal tuberculosis. And this one death case, which is still under investigation. So at the moment, we don't have conclusive evidence to say that what are the sequence of events that led up to the death in this case, because mortality has been so low elsewhere. But just to capture the essence of this slide, self-reporting to the healthcare providers has been the modality for case detection in India. Whether we look at the cases which were reported from Kerala or the Delhi cases, it was the people themselves who recognized that in the wake of the news reports and the media hype around monkeypox, they recognize that they are suffering from some symptoms which require further investigation. And the clinical providers, the private health sector, rightly took the call, suspected the disease, and undertook the laboratory confirmation, which thankfully ICMR, in a very short span of time, it set up a network where these samples could be sent and tested. As of now, this is the recent courtesy ICMR, which presents this daily report to the ministry, that we have around 184, precisely today morning, 184 samples sent from different states. Most of the samples are from Kerala, as can be rightly pointed out, due to the contact tracing activities that have been carried out, then followed by Delhi, Maharashtra, UP, and Tamil Nadu. And of this, we know that 9 have been tested positive. What's the evidence that we have currently on the epidemiological aspects of the disease? A large series was recently published in New England Journal of Medicine, which is widely quoted as to a bulk of evidence that we have. So in that, 528 cases, confirmed cases, were analyzed. And it was found that all the 528 cases were males. 98% of the cases reported among gay or bisexual men. The median age was 38 years, and 40%, more than 40% of the persons were living with HIV infection. So they were already immunocompromised in some way, and they had HIV infection wherein monkeypox was reported later on. The mode of transmission was also explored, and it was suspected because I'll talk about mode of transmission in a little while. It is difficult to establish the exact mode of transmission, but 95% of the cases were suspected to be transmitted through sexual route. Other routes were also suspected, which included contaminated fomites, large respiratory droplets, and close or direct contact with the skin lesions. The paper also concluded, and these are interesting findings, conclusions from a public health point of view, that it is the changes in the biological aspect of the virus, changes in human behavior, or both. And therefore, this epidemic is driven by waning smallpox immunity. Dr. Pragya did refer to this, that the people who are born later, therefore, the age if we are looking at, which is around 30 years, 35 years, mid 30s, this is the age group which is not protected from the smallpox vaccination efforts, which were continued till late 70s and early 80s. We are also looking at a possibility of probably, this is what the paper NGM article at least concludes, that relaxation of coronavirus disease prevention measures could also be playing a part here, resumption of international travel, and the behavioral changes which are associated with large gatherings. They could all, at least in part, be responsible for driving this epidemic. There was another series of cases published in the recent CDC and MWR, and they analyzed 1,195 cases of the 2891 cases reported in the US. This is also interesting finding that even in a country like US, which has a good reporting and recording system, the response rate was low, that only around 1195 cases, that is a little less than 50%, they offered to respond to the detailed questionnaire. So we realized this in India as well, that it is difficult to get epidemiological and public health information from the cases. But from these cases which were analyzed, it was seen that 99% of the cases were among men, and 94% of the cases did report male-to-male sexual or close intimate contact during the preceding 3 weeks before symptom onset. Also, 42% of the persons did not report the typical prodrome as the first symptom. And genital lesions were reported, which could be one or more. A single lesion was also reported amongst almost 50%, 46% of the cases. So presence of genital lesions, therefore, we did take this into consideration and when we looked at our case definitions. I'll come on to that in the next slide. 41% here also, as with the NEJM series, had HIV infection. The findings suggest that community transmission of monkeypox has disproportionately affected certain high-risk groups, which are currently gay, bisexual, or other men who have sex with men. Thus, the public health efforts, the paper concludes, should prioritize the above-mentioned group of people for prevention and testing, while addressing equity and minimizing stigma associated with the disease. We recognize the importance of these measures, especially the part about minimizing stigma. So, taking into consideration these findings, our case definition for suspected case, and the people, especially the IDSP team, is well aware of the case definitions, and they would readily recognize that this suspected case definition for surveillance purpose does not have an international travel history being captured here as an essential criteria. So for the suspected case, any person with any age who has an unexplained acute rash anywhere over the body, but due consideration should be given, and specifically it should be ascertained if there is acute onset anogenital lesions anywhere. Plus, there may be other symptoms which would be, as has been mentioned, lymphadenopathy, fever, headache, body aches, or profound weakness. That is enough to put a person in the suspected case category. And for the probable case, because we recognized seeing the daily cases, how they were detected, wherein the treating physician had a high index of suspicion of how the clinical picture was presenting. Therefore, even a clinically compatible case where the physician is justifiably convinced that this could be monkeypox, so that is enough to send the samples for testing, which is confirmed by the ICMR network, as has been said. 20 laboratories are already in place, and there could be further more if the need arises. So what should be the surveillance and response, coming on to the last part of my slide set here? The reports suggest that concurrent sexually transmitted infections are common in cases with monkeypox virus. So this presence of STIs and the findings that it is so far being reported in a particular high risk group, that's a strong indicator to develop our own surveillance strategy. It cannot proceed on the lines of the other outbreak prone diseases under IDSP, what we normally do, that there is a community reporting, there's a health facility reporting, and there's a reporting from the labs. So the SPL form based supplemented by media scanning. This form of reporting would not be able to capture the true essence or the true burden of cases. We would be missing on those groups where we should precisely be looking for the presence of this infection now. So in such a setting, specialized surveillance modalities such as sentinel surveillance, which is often deployed for RTI, STI, HIV surveillance, that could prove to be a better alternative because it specifically targets the high-risk groups where we may have a higher probability of detecting this infection now. Therefore, public health measures should incorporate the recommended interventions for other conditions occurring among high-risk groups, which are HIV, STIs, substance use, and viral hepatitis. So pointing towards a high-risk group where we have a higher chance of detecting the hidden infections. As has also been said that there are reports of asymptomatic infections as well. As has been said, there is no specific treatment, so our management is essentially symptomatic and based on the criteria that have been laid down, that we can discharge a patient safely after a certain period of time when clinical recovery has been accomplished. We also note that there are no approved medications in India as of now, and the vaccines also which are available have a limited use in certain countries, but not widespread. While we talk about treatment and vaccine, we should also give a thought to whether vaccination would be a strategy for a condition where we have limited number of cases, where asymptomatic cases may also exist, and we are still answering questions related to the COVID vaccination, wherein 2 dose, 3 dose, the 4th dose in some countries, and the purported benefits versus the risk, and how would these two vaccines, or what kind of an interaction, if any, these are the questions which the experts would like to address before we think about having vaccine as a potential weapon. So to conclude, what are the take-home messages from a surveillance and response perspective? At the moment, the system has more questions than answers. Some of the important questions that we are trying to address here are, why are the cases spreading now after so many such a long interval between the initial few clusters? Some of the answers we have certain hypotheses, but then conclusively it remains to be established that why it is spreading now at such a pace. Why among a specific group? If the virus is contagious, if it is spreading, if there are certain changes in the virus that have been by way of mutation and evolution incorporated, then why among a specific group? If the infectivity is high, then why we aren't seeing more number of cases as would have been expected? What are the definite modes of transmission? This is linked to the previous question. Labeling sexual transmission amongst a high-risk group makes the task even more difficult. If the stigmatization or if this evidence exists that the existence of monkeypox points towards or is an indicator of a certain high-risk behavior by the said case, it becomes very difficult to elicit the information required for contact tracing and containment. And who should be considered as contacts? We have seen in our 9 cases so far, there hasn't been any epidemiologically linked case in the contacts that have been identified. Despite history of close contact being given to the extent that there has been sexual contact being reported, there has been sharing of bed and linen being reported by the case and the family contacts. But so far, we haven't seen any of the contact developing the disease. Isolation and discharge guidelines also need to be deliberated. We do have a difference of opinion whether a person should be virologically cured or whether clinical cure is enough to release the person from isolation and discharge from the facilities. In our setting, we are still mandating facility isolation as the default mode, while globally most of the countries are recommending home isolation. So because this is also related to a prolonged period of isolation and the issues pertaining to livelihood and jobs. For Kerala, I understand that people are workers abroad. So at some stage, there might be a question about these people wanting to return to their original jobs in other countries. So that this is an important consideration. Then we look at why the death. Amongst 9 cases, there's also been a death. So a detailed investigation into what are the possible causes why this death has occurred. Were there any comorbidities? What were the sequence of events leading to death? Globally, there's only 11 deaths reported amongst 32,000 cases. So all those 11 deaths need to be scrutinized by the global public health community very minutely. And then, thankfully, we have Dr. Vinod Staria today, who's an expert on genomic aspects of viruses. So what is the difference between these three variants in terms of, or maybe the other variants in terms of the public health impact? We are looking at two clades. We are looking at three different types of viruses. So in terms of public health impact, what does it translate into? Can we say that at this stage, maybe this virus isn't actually the one, at least that has been sequenced from India? There are very few sequences that sexual transmission is not the predominant mode of transmission, or is it more or less transmissible than the other viruses? So these are the questions that the genomic experts would have to consider. However, we do know that there's a limited role of points of entry. So action at airports, international airports, wouldn't lead to much of an outcome in terms of detecting the cases or containment measures, given the long incubation period of the virus. However, in the case of Kerala, we have seen that people who had full-blown symptoms, quite almost characteristic symptoms, they were able to travel from these countries. And this has been flagged through the international health regulations route to those countries from where these people had embarked. Presence of such symptoms, especially when a PHEIC has been declared, poses a risk to the co-passengers and the flight staff and other people at the airport. So they should not have ideally been permitted boarding in those countries. We may see more cases that are epidemiologically unlinked to the existing ones. All these cases that we have seen, they are not epidemiologically linked. So there is every possibility, given the way the pandemic is progressing in other countries, we may also see more cases being reported in the near future. Or it may be difficult to establish linkages. That is more important. We may come across a case which actually may have been linked epidemiologically to an existing case. But given the stigma, given the type of messaging which is ongoing, it may be difficult to elicit that information to establish those linkages. We also recognize that if the global evidence is any indicator, there could be a risk of monkeypox virus establishing itself in certain high-risk groups at least. And once it gets established, maybe as an STI or depending on the new information that we get, it is quite possible, or it is always persistent threat that it may cross over to the bridge population and to the general population at some stage. Stigmatizing the cases can make detection and control even more difficult. I have referred to that in none of the 9 cases, the 8 cases that we have and the one that died, we could clinch the source of transmission or the mode of transmission. We do have hypotheses, we do have certain circumstantial evidence, but to clinch that mode of transmission and source of infection, it hasn't been possible so far. So what is required is a close collaboration amongst all stakeholders, which is the private sector, which has seen these cases in the first instance most of the times, the laboratory network which ICMR has developed, ensuring that labs are available virtually on almost every part of the country, the surveillance programs, which is both the IDSV in a way currently handling it, and moving forward, maybe a specialized surveillance through the National AIDS Control Program and its targeted interventions. And also the NGOs would have a role here to, well, this is what is required, a close collaboration among these stakeholders to deal with this complex problems. And the laboratories would also include genome sequencing laboratories and centers such as the ones headed by Dr. Vinod Staria and team, which would help us answer these questions at a molecular level. So to conclude, I remember PSH madam had mentioned that what are the possible areas that the state should be concerned about, or they should be looking forward to. I would say, madam, that a real-time case-based surveillance system, the emergencies would come and go. This is one we are dealing with right now. Maybe it may ultimately die down without leaving any trace, but that doesn't mean that we may not face another public health threat in future. So a robust surveillance system, which is real-time, that is sensitive enough, which is case-based so that we are able to identify the cases, electronic, moving with the times, is probably the need of the hour. And I'd like to thank Kerala in its initial stages when this kind of a surveillance platform was being designed and envisaged, where Kerala took the lead role, and IHIP, Kerala was one of the first states where it was piloted. It is probably time that we graduate onto the next level and implement IHIP in a more robust manner. So that's about it from my side. I'll stop here and thank you very much.